Welcome, everyone, to this episode of the Marketplace's Free Market Cash Patient. I'm your host, Jeff Cantor, with a very special co-host, Dr. Robert Campbell. We're sponsored by the Marketplace, as I said, which is at your-mp.com. And you're going to definitely want to take advantage of taking a look at that, because we are the disruptors intersection, and today is no exception. Now, first off, just to point out the obvious, there's some serious problems in the healthcare industry, and we're going to really delve into one of them yet tonight. And needless to say, it's getting pretty complicated. And you got to imagine, how much does all this cost? And not a penny of it goes for healthcare. And how many people is this supporting this? And this is just one part of government healthcare. And then, of course, now prices of health insurance have reached a point where it's bigger than your mortgage. So a lot of people are trying to figure out, well, how do I get some equity back out of all that money I've been pumping out? And then, there's all sorts of information on what you should and shouldn't do. And it's caused an awful lot of distrust in the healthcare industry in general, which is to our advantage. It's sad for the consumer, but sometimes need to get really bad before we take a move. And you see where they're moving themselves, which is not a healthy place. So we're just really excited to get out of that. Now, on the site itself, let me cut out of here one second. If we come over to the website and you kind of hover over home, you'll see there's webinars and continuing the conversation. A lot of other great drop downs too. But under the continuing the conversation is the important part, because that's your chance to connect with our guests after tonight. Tonight is really just the intro. This is hardly a one and done situation. And we've got some fantastic people that go back for years and years and years. And sadly, a lot of this stuff is as current as it was at the time they presented it. But let's take a look where we are tonight. So if we come over to the webinar page, let me pop to the top here a second, and you scroll down, it tells you about the two series we do. Here's the earlier one today. Here's the one for now we'll come back to in a minute. Here's a little bit about our special co-host, and here's coming up. But here's the important part. Here's where the links are found after this recording is released. So as an example, if we take a look at this Brighteon version of what we do, you'll notice there's years and years of fantastic guests. All of them, I have to say, I don't think there's a bad one in the bunch in here, really. So you're going to definitely want to come in here and take a look. So, but let's get going on tonight, because I know we're all waiting with bated breath to find out what Matt's up to. So Dr. Campbell, I'm going to have you give the introduction, but first let me tell you a little bit about Dr. Campbell. One, he was an advisor in the Trump campaign for quite a while, which is really critical. He has his degree in biochemistry. He's an anesthesiologist and in pain management. But for the consumer and for doctors, he started Physicians Against Drug Shortages, Free to Care organization, Parents Rising, Physicians for Reform, and healthcareforyou.com. So he's really got his finger in the pulse of where we need to go. But on that note, I'm going to let him do the honors and introduce tonight's guest.
Well, thank you, Jeff, and welcome to everyone to the Freedom Hub, where freedom still exists. It's one of our most precious attributes that we have in the United States. It isn't always available elsewhere. Today, we have Dr. Matt McCord, also an anesthesiologist. Anesthesiologists have been disruptive innovators during mine and Matt's career, that's for sure. And we've done a lot to make healthcare more safe. People like Dr. McCord have also taken the next step to say, well, we don't want to just make it more safe. We want to make it more affordable, more accountable, and more patient-centered. And that's, as Jeff indicated, I've been involved in so many different groups. It all centers around one thing: making healthcare accessible, making it affordable, making it patient-centered. So with no further ado, Dr. McCord, let's tell the world how anesthesiologists can fix this very large healthcare policy problem.
Fantastic. And on that note, I'm going to stop sharing and I'm going to give you the screen there, Matt.
Okay. Well, thank you, Jeff and Dr. Campbell. I appreciate it. Let me get this my presentation up, and here here we are. Let's see. Okay, everybody can see my screen? Actually, Dr. Campbell, it was interesting to hear your background. I too was quite active 10 years ago during the Affordable Care Act. Politically, I was one of the state officers for the Michigan chapter of Docs for Patient Care. I was active also in the AAPS and wrote many opinion pages back then. And I had a 10-year hiatus or walkabout, and I finally got back engaged in helping to drive change in healthcare, which is what the Affordable Care Act had promised, but we really haven't seen yet. So the title of my talk is Moving to Value in Healthcare. Last year, I became a health benefits agent because the majority in the commercial market, of course, Americans enter the marketplace in the healthcare world through an insurance product. So in order to kind of get rid of the middleman, I had to kind of become one too. So I guess if you're going to eat sharks, you have to kind of become a bit of a shark. So trying to help shrink that middle, as Steve Klasko, the MD CEO of Jefferson Health, talks about, geez, in few other industries have we seen such a growth of the middle of an industry like we have in healthcare. Maybe healthcare and post-secondary education are all that I can think of that, where we've had this exponential growth of the middleman in healthcare, and they're basically displacing both the caregiver and the care receiver further and further apart, which adds to problems with safety and costs and what have you. So that's why I became a health benefits agent, and I started an agency, consultant agency called Health Value Solutions. Oddly enough, I was able to trademark fair trade in healthcare. No surprise to anybody probably in this room, but started that last year. I did that alongside of a licensed benefits agency here in Michigan that's been in the business for over 40 years. So we create benefit plans for employers, helping them buy healthcare smarter. The idea being really creating a demand for and a funding mechanism for value-based healthcare delivery. And I'll explain more of that as we go. This is one of my favorite slides. If you're really gonna, big picture, compare us to the OECD nations. And this is data from the World Bank and the OECD. And there's a great site called Our World in Data. You could look this up, but it really shows how much the United States is a huge outlier in not only cost for healthcare and health expenditure, but also now life expectancy, which partly is our obesity problem, but it's a lot of other problems too, including medical error and others. So we really need, what the whole idea too is really fixing this graph and affecting this graph to get us more competitive with our other OECD nations. We all know this, excuse me, I'm sorry, this is very touchy. We all know this in this group. The costs of healthcare are becoming unsustainable. Now the average American worker with a family, anyway, is spending well over $20,000 a year in health benefits and premium costs. That's like buying a new mid-size sedan every year to insure their family. It's really it's unsustainable. The average American worker, if they're making $60,000 a year, it's really eating their wages. And that's why I think we hear a lot about increasing the minimum wage. It's really because healthcare is eating wages. In the Bloomberg has a great article on that about 10 years ago that talked about, about 8 years ago, that talked about how really since the 70s, wages have stagnated because of the increased costs in healthcare. And healthcare literally is eating wages. And since the Affordable Care Act, we started to shift costs to healthcare to the worker in the form of higher deductibles. Premiums, as you see, are going up. Workers' earnings are kind of going up, but not nearly as much as deductibles. What's happened there is now workers, basically, when faced with added deductibles, are essentially functionally uninsured because many of them are not getting the care that they need. Despite paying more and more for health insurance, they're really not getting health care. So that's when I started Health Value Solutions. You can see my website there, healthvalue.solutions, and you can reach me, by the way, at matt@healthvalue.solutions if you'd like. You can scroll through there and I give examples of how we help employers, how we help providers in the direct contracting world. And I also talk about opioid-free and opioid-sparing surgery, which I'm going to get to in a second, which I think is a great opportunity to start delivering on value for a very motivated workforce. How we are different, I call Health Value Solutions basically a health benefits management company. We are really not a group benefits sales organization like exists in the current marketplace, or the most legacy group benefits sales agencies are really actually sellers agents. We know this business model. We understand it quite well, I think, with this group. But, they're getting paid by the carrier most of the time. So most organizations receive payments by the carrier, and that model is inherently flawed because when costs go up and premiums go up, both the carrier and the group benefits sales agency make more money. So the incentives are not aligned. On the other hand, we are, as a benefits management company, we're a buyer agent where we get paid by the employer only. We are carrier agnostic. We can use any carrier. We can even do fully insured, fully bundled, fully insured plans to level funded plans to fully self-insured plans. And we run the whole gamut. Typically, we can unbundle pharmacy benefits. That's a whole quagmire of costs and rebates and kickbacks that we can remedy and lower costs there. We have benefit design expertise. We have healthcare delivery expertise. I've been 30 years in the business, so I'm going to help with that for these employers, and we're doing that now. We provide new technology that already exists in the marketplace that really doesn't exist in the typical insurer world, because that makes care a little more efficient and less costly, which kind of goes against the business model. So that's why you're not seeing a lot of that new technology that's out there that really is not really made it to the marketplace, because it's really counter to the current prevailing, I should say, business model in the industry. We provide actionable data that the employers can use to lean manage their benefit spend. And we provide some direct contracting and care procurement, as well as chronic care management, which is really population health. What we're doing is really helping the small market employers that have less than 1,000 workers. We are allowing them to really purchase health benefits like very large companies. This sort of management scheme is already well established in the marketplace. 86% of employers with over 1,000 workers are self-insured, and they're doing a lot of these, implementing a lot of these elements. In these smaller employer groups, which is 80% of the market under 200 workers, very few of them are actually self-insured. And the ones that are self-insured are not really benefiting from that arrangement as much as they likely could. So we're helping employers do this a little smarter. You guys also likely know this. There's variable costs in medical expenses. 80% of the spend is in these medical expenses. We help manage those up front and change care delivery. We don't focus as much on the fixed cost. You can make a few changes there, but mostly it's these variable costs that we're focusing on. And that's how we help employers save money on their benefit spend and their healthcare spend. This is the Health Rosetta framework. I'm a Health Rosetta certified advisor. You guys have probably heard of Health Rosetta. They are really a grassroots national organization started by a friend of mine, Dave Chase, who I met 10 years ago. talking about the Affordable Care Act. And after reading some of his articles in Forbes, he is a healthcare tech entrepreneur, sold his business to WebMD, saw the problems in healthcare delivery, became part of Microsoft's healthcare business, and then started off on his own to create Health Rosetta, and a great champion of this disruption in the health benefits space. The Health Rosetta framework includes what's seen here and how we are changing things, and how that might affect the overall cost and the health benefit spend for a company. Specifically, value-based primary care. You've heard of direct primary care, I'm sure, in this group. We absolutely, again, create demand for that and fund that, so employers can have their workers properly cared for. That's a foundational piece to our fully employed solution. And then finally, we do not only transparent open networks and greater transparency, but we also directly contract with specialty services, and I'll explain some of that in a minute. Now, getting on to a great opportunity for specialists like myself as an anesthesiologist. I happen to be a regional anesthesiologist. I do a lot of acute pain care and orthopedic surgery, for example. So that's near and dear to my heart. We started engaging with large buyers of care. These are the bigger buyers, large trade organizations like the UAW and the building trades, where they have a lot of workers that have a lot of physical labor work. They also, these workers cannot miss a day of work. If they don't miss a day, they're not putting money into their retirement benefits. They're not doing well. So consequently, they go back to work with injuries, and they have significant injuries. And about 20% of those workers on the lines and out there working on construction are on chronic opioids. This is a huge problem for this organization. And we approached each other, I guess it was kind of serendipitously, that is there a way we can get in front of this problem instead of treating substance use disorder? Can we kind of prevent the problem from happening in the first place? We started having discussions with them. Probably about 5 years ago. Well, if we look at disease burden, and if you do combine mental health and substance use disorder, that's by far and away the number one disease burden. This is from the Institute for Health Metrics and Evaluation, and quoted by Kaiser Family Foundation. In terms of disability adjusted life years, it by far and away exceeds cancers and cardiovascular disease, injuries, musculoskeletal disorders, which can become that, of course. But if you're going to try to solve for value or solve a problem, maybe this is a great way to begin, and I think it is. I'm an advisor as an anesthesiologist. I'm an advisor to the Michigan Open, which is the opioid prescribing and engagement network here in Michigan. And we really try to use benchmarking information and share data with other providers in the marketplace to help avoid and limit opioid exposure and proper opioid management, if you will. Having surgery puts you at risk for opioid use disorder. And really, unfortunately, I think the new thinking should be that if you're on opioids after 90 days after a surgery, that is a medical error or a complication of any surgery. I'll say that again. I believe that the new thinking should be, if you're on opioids after 90 days from an elective surgery, not maybe a trauma and not other, acute events that were not elective, then that should be treated as a medical error or a surgical complication.
As usual, another great guest, but a quick diversion. You'll notice that our full name is the Marketplace for Health, Wealth, and Freedom. Well, let's talk about your health for a moment. If you'd like to escape from the stranglehold of insurance and be able to see alternative doctors or go across state lines for care, then you definitely need to take a look at patientempowerment.mpb.health and see if that's the fix you've been looking for. Now, let's get back to the show.
And here's the rates of opioid use 90 days after surgery for these various surgeries. If you look at gallbladder, lap choles, or even thyroid surgery, which is a very small incision in the neck, the lap choles, small incisions in the abdomen, there's about a 6% chance that you're going to be on opioids in 90 days. For joint replacement, it's anywhere from about 7 to 12%, depending on the study, for knee replacement or hip replacement. Knee replacement being a little higher incidence of being on opioids in 90 days. It's up closer to 9 to 10%. Hand surgery, kind of crazy, but carpal tunnel release, a very minor surgery, actually is fairly high in chronic opioid use. Being on the extremity, maybe that, where we have a lot of sensation on our hands as we've evolved. It's common for those folks to be on opioids after surgery. But what's particularly worrisome, I think, is seeing this breast surgery, mastectomies and what have you, is almost 20%, 1 in 5 patients will be on opioids 90 days after a mastectomy. And we know how common, unfortunately, breast cancer is and how common mastectomies are. That's an unacceptable number. It took us a while to figure this out, but we now know that really it's only within about 5 days of being on opioids that your body starts to adjust to being on opioids and these external endorphins. And really, I was taught 2 weeks or so, 10 days back when I was in medical school, which I finished in Wayne State University in 1989, a few years ago, and right before this opioid problem. But we used to, again, at that time, the dogma was we would not prescribe opioids to anybody unless they had terminal cancer on a chronic basis. My, how that's changed. But now we understand that it takes about 5 days till getting off opioids after that. If you've been on 5 days straight, you're not going to feel very happy as you try to get off those opioids. You'll feel unwell. And that is a problem. And then as you can see, if you're on opioids for a month, you got about a 40% chance, 45% chance to be on opioids after 1 year. So this is how quickly the opioid problem can develop when taking opioids. So you really need to be careful about that. This IPOP study was a great study that just came out actually last year, comparing the US and our prescribing habits compared to the rest of the world. They looked at 16-year-old or adult patients, or what we consider essentially adult patients or greater, for three simple surgeries, appendectomy, laparoscopic cholecystectomy, gallbladder removal, hernia repair, 14 hospitals, 8 different countries, almost 5,000 patients. And for the US patients, 91% were given opioids. For the non-US patients, only 5% were prescribed opioids after those surgeries. Our refill rates were 4.7%, whereas in the non-US countries, only 1%. I think we have a problem here. I think both on the provider side and the patient side, and the expectations that they're going to be sent home on opioids, we need to change that thinking. These larger buyers of care are very active politically as well, and they understand kind of how to really change the narrative, both politically and commercially, as they leverage the industry. And they actually, here in the state of Michigan, the UAW was very instrumental in enacting a non-opioid directive which became law in 2019. That directive basically is like an advance directive for the hospital for any patient that comes in where they refuse to be treated with opioids when they're receiving acute care. Very interesting idea. You could see that it gives, you could see a little in this upper right, this is a portion of the form, but it gives the hospitals, of course, the option in the case of an acute MI or some life-threatening emergency that we can absolutely administer opioids, and we're not going to be held accountable for that. But if they're putting a stake in the ground and saying, if at all possible, I would like not to receive opioids for my care during this acute stay. And there are some changes going on with this law in this state where this is being entered in the medical record and put under advanced directives and listed essentially as an allergy to opioids for most institutions in the state of Michigan. We're the 7th state to enact this sort of law, and other states are considering it. So you might see it in your states as well. I think we have this current expectation, as I showed you, that we are way over prescribing opioids. We need to really probably consider anchoring to zero exposure, shifting down our thinking to no opioids after so many days. I think it's very reasonable based on what I showed you from the CDC and the MMWR, that after 5 days, you're not going to really like coming off opioids. I think that's a very reasonable endpoint for being off opioids, and I've demonstrated that in our facility, and I can explain more in a second under questions. And what if we anchored to zero opioid pills as would be the norm and adjust up, and what perioperative pain management pathways would need to be built to eliminate or decrease postoperative opioids? Well, we've actually addressed some of that within our organization and our facilities, and we actually give patients really their own recipe for their non-opioid therapy post-surgically, and make sure that they stay on schedule with that to minimize the need for opioids. And we've been very successful in doing that. I've sent over 50 patients home after total knee replacement on no opioids, for example, and they haven't come back for more. They haven't been readmitted to the hospital, and they haven't wanted more. And that is the end of my talk. I'm ready for some questions.
That was very good. What have you seen? And if you want to stop sharing, we can get you on camera there.
I'm sorry, I will do that.
That's fine. What have you seen in terms of any other things to use? I see a lot of people trying to combat opioids with CBD with some big success, especially amongst a lot of senior population.
I actually like that idea a lot. I think that's very an interesting area to investigate on that. I use a lot of regional blocks for total joints. I use Adductor Canal catheters, they're called. We put these right near the saphenous nerve underneath the sartorius muscle, leave those in place for a couple of days and run that continuously. So the anterior portion of the knee, about the front 30%, is really anesthetized for a few days. Particularly, again, we want them to do physical therapy within 2 hours of finishing the surgery. We want them to walk to the bathroom. So we need to numb things up too. I'm also utilizing IPAC blocks or a posterior, an injection on the posterior cap, near the posterior capsule of the knee. I do that at the same time pre-surgery, so they could extend their leg, and that takes care of most of the posterior pain in the knee capsule post-operatively. There are some other really interesting new innovative medications that are coming to market. Full disclosure, I'm working with a couple of them to help promote them in the marketplace and talk about them. But one is Angesso, which is an IV meloxicam, which is very long acting, which is really helpful perioperatively. And the other is Zenrelief, which is really a long acting bupivacaine formulation with meloxicam that lasts a legitimate 72 hours. That first 72 hours is really the key piece to solve. And you've got to take care of that first 72 hours to really impact this opioid problem. And so there are many, many strategies to do that.
Excellent. Charles, I see your hand is up.
Dr. McCord, thank you for that presentation on how to use the Rosetta benefits and the surgery part to push back an opioid problem. I was a lobbyist, and still am, for years, decades, and in the 2000s, I had as a client the Pain Relief Organization, which represented a lot of pain doctors being caged for overprescribing. And I learned some things that people don't like to hear. And that's sort of the other side of this opioid issue. And real briefly, what I learned is that the poppy plant for thousands of years has produced the medicine for long-term searing pain. And, you know, isn't there some nuance in this whole opioid hysteria, in that if you're not going to get OxyContin or Dilaudid or Vicodin, you know, the doctors may push something even worse on you, some NSAID with a lot of side effects around the heart and other. So there's no real perfect answer, number one. And number two, we've had on this program over the years, the surgeon, Jeff Singer, a scholar at Cato, and then Lauren DeLuca, who's an advocate for pain patients more recently. And isn't there, when you squeeze the balloon on legitimate pain patients and their reliance on opioids, sometimes long-term, that you're sometimes, and you get these pharmacists to, you know, refuse to prescribe adequately. You know, if someone's in long-term searing pain, sometimes they need it for that contractor working on the job with opioids. You can't tell they're on drugs because they're a long-term user. Yep. That balloon gets squeezed to looking for heroin on the streets, which is cut with fentanyl, and they die. So is there one side of this opioid issue, or is this kind of nuanced, and we have to kind of be open-minded on just how difficult this is to figure out?
Yeah, thank you, Charles, for bringing that up. Absolutely, it's nuanced. This is healthcare. We're all different, thank goodness. We're all on a bell curve about things, you know, with our conditions, how we sense pain. We are all different. And there are absolutely a number of conditions that are chronic that may require long-term opioid therapy. And those patients absolutely they deserve to get cared for. And you have to customize your approach, just like with all of us. So no, yeah, please don't, but I can tell you that I do think for acute care, for patients that don't have any of those risk factors, are not already on opioids, I think a great many of the population would benefit from a different mindset and a different strategy for perioperative surgical or acute pain care. I do think that this provides a great opportunity as well for forward-thinking surgeons and anesthesiologists. I'm talking to you, Dr. Campbell, by the way, to begin direct contracting, excuse me, with, I got to get a water, with employers to provide this sort of service. And in fact, the large labor organizations in this state up here in Michigan have a keen interest in doing that. And not only that, but paying more for the better care outcome.
Very good. I was going to actually ask Dr. Campbell to kind of put a 2 cents in here on that.
Yeah, I've practiced pain management for 31 years, and I've seen the pendulum swing back and forth. And I was in Harrisburg, and Governor Rendell gave me the proclamation that the 2000s were going to be the decade for pain treatment. And we were not going to have, if doctors could just prescribe more pain medicine, we would have no pain in the state. And of course, I took that, and I didn't say anything, but I said, oh boy, this is an overreach. And then, of course, when I was in my training, we didn't prescribe narcotics for just about anything except cancer. And so I think that there is a nuanced middle ground. And I think the key is, and I'm giving my opinion from my experience, I've had little old ladies who used to take half a Darvocet once a day. They were 80 years old, and they did their laundry and they did their work, and they got around, and they never asked for one pill more. And then you have people who, no matter what prescription you give them, in 10 days, it's been lost or flushed down the toilet or stolen, et cetera. So there is that subset of aberrant behaviors which identifies itself, and then they need a different kind of care. They need care, narcotic addiction care. And we see it in the surgical suites when the post-op, when, you do like a carpal tunnel and all of a sudden you got a guy who just can't get off the narcs. Well, that's the addictive patient. So it is complex, and it's not going to be a simple cookie cutter solution. And it gets back to where if we can deliver our overall healthcare more efficiently, more value focused, save a ton of money from pharmacy benefit managers. I'll just say that's an area of expertise for me. If we could save 43% on the cost of prescriptions for pharmacy benefit managers, we could repurpose that to addiction care. And then we would get excellent addiction care. And then the surgeons wouldn't have to worry so much. If somebody was taking too many narcotics, we'd have a place to send them. So that's my nuanced explanation, and appreciate the venue.
Thoughts, Matt, on that?
Yeah, no, there is that Purdue Pharma legislation. I think the state of Michigan's getting something like 900 million as part of that. And unfortunately, a lot of it's going to medicated assist training or substance use disorder treatment. And a lot of it should, and that's treating the problem after it's developed. It'd be nice if some of that money was spent towards more proactive ways to manage acute care delivery to prevent this bigger problem. As many as 130 Americans are dying from overdose. It's actually even higher since COVID by 30%. But about 54 times that amount are becoming opioid addicted each day. So it's just a exploding problem that really we need to start getting in front of and start avoiding the problem before it starts, if we can, by changing how we deliver care.
It's important to start before it happens. Sam, I see your hand is up. You have to unmute yourself there. Maybe we lost Sam. Well, in the meantime, I see Charles's hand up as well.
Yes, Doctors McCord and Campbell, I'd like to hear you two exchange in a conversation about that direct contracting, because Matt, you're right. We have on this 3-year-long Earning Freedom Hub program had a lot of Rosetta advisors, and getting the specialists to go cash in whole or in part is key for a lot of reasons, not just helping the employer get some better care for his employees. So I'd like to have you and Robert talk more about that dynamic, because that has so many ramifications, all good, I think. Getting the specialists to go more independent, get more cash, and how that might help the market, opioids or otherwise. Is that clear, that question?
Absolutely. Dr. Campbell, you want to go first, or?
Yeah. I am a firm believer that, we've given the keys to the insurance companies, and what we have is 15 to 20% healthcare inflation. And oh, by the way, there's not enough money for you to see a doctor. You have to see a nurse, or you have to see, because, and of course, the system's not working. I am firmly convinced, after trying to reform healthcare the practical way through lobbying and appealing to people's spirits about what is good healthcare and how we should get there, and changing policy, I think we need to create an alternative universe where we have a competitive free market. The costs will be cut in half easily, but it takes a group effort for people to start believing in it, and it's a tough thing. What I would tell you, Dr. McCord, is with your orthopedic surgeons, and I tell my guys this all the time. I say, save 1 seat out of 10 in your waiting room for a cash pay patient only, and what will happen is everyone will want all the seats to be cash pay patients before you know it. You don't have to deal with all the, and of course the key is the Rosetta brokers, getting employers to believe. I can tell you, I've had so many people who just don't want to put the time into it to be convinced, or they just aren't believing that a free market approach will work. And even in light of the fact that the current system is completely broken, look, Einstein said, the insanity is doing the same thing over and over and over again and getting the same stupid results. So let's try something different. So I would appeal to the Rosetta brokers to convince the employers to try something different. And I think doctors will flock to it if given the chance. So Dr. McCord, I'll let you speak.
Yeah, I would agree. And I think that's really the destination. But getting there, I think, requires a bit of nuance. And the solutions, particularly if you're going to get employers to buy in, the solution needs to be, and I've experienced this personally as I've tried to start this consultancy, is that the solutions need to be evolutionary, not revolutionary. We take steps towards going completely full value-based care delivery. And it has to work in our current market or look quite similar and be competitively positioned. So it's something that's consumable and doable in the minds of these employers. And so you have to start implementing some of these elements sequentially. We call it really basically the crawl, walk, run, fly methodology. And it's really a 3 to 5 year plan as we transition a employer to a fully Health Rosetta design benefit solution. One of the first things we did when we started getting wind of the fact that these large buyer organizations, very large, these are Taft-Hartley employers that are part of the Taft-Hartley union employers, large trade associations, the UAW, et cetera. Well, their benefits agents are, national organizations, benefit organizations, and they take this stuff really, quite seriously. We started having a discussion about this, and we actually had, next thing you know, I had like 3 different specialists come over and tour the facility, not unlike the Joint Commission review, to see that, we can do what we say we're going to do, and we'd like to directly contract with you for opioid-free joint replacement. And not only did they have a keen interest in doing that, they actually, when I first proposed this to one of their first meetings, they stopped me 10 minutes into it and said, could you come back tomorrow for our national board meeting and present to everybody on the board? And I did. Next thing I knew, I was in front of 30 people with 5 lawyers in this corner and the benefits agency in that corner, and everybody's talking about how they can get this done. And it didn't take long for them to figure out how to do that. Not only that, the interesting thing is I just said, okay, I'm going to start with, 300% of what I normally get to do this work. And so I already made the calculations in my head. Of course, I'm not talking facility fee, which is a little 10x what the surgeon and I are getting. Well, actually more than that even. But I just said, well, you're going to, this is added work to help manage patients, particularly out of hospital, to make sure that they're staying on track with their other medications, make sure they're not being lost to follow-up and all that. And with these big buyers, that's in fact exactly what they expect. And I said, this would cost you this number. They didn't even stop, didn't hesitate whatsoever. There was no negotiation. They absolutely were all in. And not only that, but they're fully willing to pay the facility fee they're already paying the hospital currently. So now I got no pushback from the hospital as a facility. All we're doing is bringing in new patients, and new cash, probably the best reimbursement patients I should say, in that vernacular, for that hospital. So it actually, was a win-win-win-win. I mean, everybody was interested. So that is a really interesting way to do this. Again, kind of thinking in the current construct and then moving over. Of course, we're going to get, as transparency increases in the marketplace, and thank goodness that it's happening, we will get down to more completely free market and individual pay. But we got to start somewhere, and this will get us early traction with moving to value.
So what about your wealth? If your money could actually talk to you, would you listen to it? Well, with the DNA Network Academy, your money actually can talk to you, and it's going to tell you just what it told this client. This family had over 24 debts, mortgages, car loans, the works. They were on track to take 20 years to pay it all off, and instead did it in 8.5. Plus, they did it without refinancing, making more money, or even changing their lifestyle. So find out for yourself with a free analysis that is completely confidential. No personal information, no social security numbers, no credit checks, none of that nonsense. But what is exciting is that the outcome of that report you receive is a guaranteed outcome for you. To get that report, head on over to bit.ly/debt to wealth. You will arrive at this simple form. Fill it in, as simple as lender number 1 and credit card number 2. What really matters is the accuracy of your numbers. You'll be able to see that if instead of 20 years or whatever your number is, that you may actually be out of debt and on your way to wealth in as little as 6.3 years, like this client. Very good. I see Sam's available again.
Actually, thanks, Jeff. Actually, the question that Charles just asked was exactly my question. Of course, Charles asked it much more eloquently than I would have, but that was my question. But while I have the mic, just one little clarification, Dr. McCord, and thank you for being here, is you mentioned care navigation technology. Do you also provide care navigators as some others do, or can you tell me a little bit about the technology that you're using?
Yeah, thanks for that, Sam. I'm actually, we are going to be using nurse navigators to help employers and employees get in front of their care experience. The two main problems that employers from their standpoint see with healthcare is not only is it costs too much, but they don't know how to use it. They don't know where to go to, they don't understand deductibles. They don't understand copays out of pocket. You can explain it. You can give a packet. They still, when they actually need care, they don't understand that. We'd like to, in the Health Rosetta mindset or model, we'd like to, create a free door A, show them where to go to get the best care, and the expensive, lower quality, not as effective care that they may have to pay out of pocket for. But we tell them, basically guide them on where to go. There are technology solutions that are out there in the marketplace that can be utilized and wrapped inside the plan document and part of the health benefit design. There are also call centers. There are companies that are doing nurse navigation call centers, as you likely know. But we want to get in front of the care delivery experience, not in the rear view mirror 6 months ago, where there's no way to act on it. We want to act on it in the front. If first, we think direct primary care is absolutely foundational to the care delivery model, and that is going to take care of 80% of the problems. And then the 20% where you need specialty care, or maybe there's a concern for a very significant diagnosis with a worker, then we not only may guide them, but we may also send them for a second opinion with some of those elements.
Got it. Thank you.
Very good. One of the nice little perks we've got today is we have an author and professor on who's in the throes of writing a book about healthcare. And so I want to see what he thinks about what he's learned from tonight, as well as what he's amassed over the time he's been working on this book. So Professor Sabrin.
Thanks, Jeff. I appreciate it. Unfortunately, I've been sort of in and out of a haze here. It's been a tough day today in Florida. Anyway, I really appreciate you taking the time to give us your perspective. And I just recently did 2 podcasts with Hunter Hastings, who does economics for entrepreneurs for the Mises.org website. And the whole key in this endeavor that Hunter has is to bring value to the marketplace for consumers. That's what it's all about. You want to get value for your dollar. You work hard for your dollar. You want to get value for your dollar. And the problem that I see it is people don't know what the value is of medical services. They have no idea because it's so opaque. It is amazing that you never see a bill. All you do is pay the copay, and then you get an explanation of benefits at the end of the month. And it's bizarre looking. You see what the doctor is submitting, and then what the insurance company is paying, and you're wondering, where's the value? Where is the value for these services? And this is the thing that I find really remarkable, that the system has evolved where the consumer is so passive in medical care that people spend more time looking for a restaurant than they do for a surgeon or a radiologist, or whatever the case may be. Having grown up in New York City in the 1950s, medical care was pretty simple. You went to the doctor, your parents paid $5 for the pediatrician's visit, you got the prescription, you go to the local pharmacy, a few dollars for the antibiotics, no paperwork, no insurance claims, no insurance company. And it was pretty straightforward. You knew exactly what you were getting. And it wasn't a 10-minute visit with the pediatrician. It was as long as it takes to get your condition diagnosed and what the proper treatment would be. So I really appreciate everyone that's doing these incredible, innovative and creative approaches, given the structure that we have today. And from my perspective, in the book that I wrote that was published in the summer on universal medical care, from conception to end of life, this case for single payer system, where the single payer is the individual family. I try to keep things very simple in my life, and I think we should try to apply that across the board. And unfortunately, and I'm going to reiterate this, I think it's a really sad commentary on our culture where people are not taking charge of their healthcare. I think that's the biggest, stumbling block we have to getting a rational healthcare system in place. And by the way, I call it medical care rather than healthcare, because healthcare is our responsibility as individuals to optimize our wellness, and medical care is what we seek when we don't have optimal health. So I'd like to make that distinction right up front, because I think we can, by conflating the two, I think we create confusion in people's minds as who's responsible for healthcare in their lives. And healthcare is the person you see in the mirror every morning, and the person that you hope you'll be able to see when you need attention right away. And moving to Florida this past June, it's been a challenge trying to get medical professionals, doctors, to become a patient. And so we're getting there. We're working on that, but it's probably one of the biggest challenges, I think, in our societies when you move to a new area and you really have to do a lot of research. Unfortunately, we found that we met a doctor in our gym in our development, and he gave us the dentist gave us a doctor, another good friend gave us another doctor. So you need referrals. It's as simple as that. People who you feel can guide you as to who is a good practitioner in your area. So again, I really love the whole concept of value. I think that's really what it's about, is bringing the value mindset to medical services. I think is critical in how we're going to evolve to a free market medical system.
Thank you.
I love it when Murray speaks. He gives such a common sense perspective. And I'll make one comment, Jeff, because I know we're getting tight now. But we're in the midst of launching what we wanted to be a national, but it's now a demonstration project in Houston. I think it's the biggest demonstration project of a cash pay launch in the country ever. And one of the key things, there's 2 big things that we've learned and that we're experimenting with. One is you have to teach the patients to be consumers again. And that's a big deal. Secondly, the question is, where should these counselors be? So we're experimenting with having, we call them Sherpas, We're experimenting with paying the DPC docs a little more and letting the DPC doctor's office have the Sherpa nurse who can basically be a counselor for shopping. You know, here I'm going to help you get the best car at the best price. You and I are going to work on it together. The other approach is to have it at the place of employment. And then the third option is to have it, you know, with the Rosetta, you know, agent and to have a centralized version of it. So we're experimenting with that. But the point is we knew absolutely we needed the Sherpa. And with time, Murray, I'll say this to you, with time, we're going to see that the patients are going to benefit from being consumers again.
Mhm.
They're going to get better and better and better. And so like when I was at my dentist's office yesterday, my dentist said, hey, who should I go to get a colonoscopy with? And I gave him a name. We're going to start having that where the patient is actually, it's on their shoulders to pick and choose and get their health care treatment. So those are my perspectives. And Jeff, I'll turn it back to you so you can wrap this thing up on time. I know you like to do that.
Sure. Well, we're going to actually slip a couple last questions in. I see BR has his hand up or her hand up. You have to unmute there. Oh, there you go.
Yeah. So, I wanted to ask a question about, some of the inefficiencies in the system, because I'm looking at autism and the treatments related to that. We're spending about $300 billion a year on the services for this community. And when you ask the parents, I'm one of the parents, what we are getting is, it's nothing, of importance which can improve the quality of life for these people. I really wanted to reach out to both Matt, Robert, and Sam at some point in time to discuss, how we can look at this space and how we can help improve the quality of life for this community, and we're spending so much, and not getting the outputs. Again, the insurance company, they have approved some therapy, which is now become a $50 billion business in the US. It's really surprising.
Yeah, well, I can tell you, there are many people affected and many families are affected by autism, and it can be, and of course it's a spectrum, and it can be devastating for families with, and very, individuals can have very high needs. So a lot of people have interest in this problem, and I think banding together is always helpful. And I know in the state of Michigan, they've been able to do that. And with these large buyers of care, and actually made sure that that was a covered benefit in the case of the UAW, as I understand it. So you might, I could get you connected to people that have done that and made those kind of inroads for that.
Perfect. That's one of the things we like about our shows. We want to start connecting influencers, and
Thank
this
you.
is a perfect example.
Mhm.
Charles, you got time to slip in one last question there.
So for those employers that are skeptical, as Dr. Campbell mentioned, whether for direct contracting or the sharing with health savings accounts or DPC that Jeff and I got featured in Forbes for selling for the small group market and individual market. You mentioned the crawl, walk, run strategy to get the employers trying something at least until they're full Rosetta clients. What real quickly are those crawl first steps where employers are more open-minded to try something?
Yeah, so we've got to first off, just to get in the door, and once we get in the door, we've got to be perceived as a viable option, right? We've got to, got to give them at least what they're getting already. we need to be able to say, look, okay, we can give you exactly what you're doing right now, and slowly move you on to what the largest corporations in America are doing and how they're helping to lower their spend and get a better, and even more importantly, get a better care experience for their workforce, and less absenteeism, less presenteeism, less other issues that they're trying to help avoid. So the first steps we would do, and you could see this, I believe, on my website, is we talk about going from fully insured to level funding, which is kind of almost self-insured, but not quite. and it's usually provided by the main, most of the legacy carriers that you think of, the BUCAs, Blue Cross, United Healthcare, Cigna, Aetna, Humana, et cetera. And then go to, from level funding, then you could at least get some information on your data and your spend. With fully insured, you rarely can get that information. One other industry is obfuscation, part of the business model. I mean, anyway, that's a whole sidelight, but we go to level funding so we could start getting the data, and then we go to self-insurance with stop loss carriers and what have you, so we can protect the downside risk and start managing this directly. And some of the first other things we do is go to unbundle pharmacy benefits and go to a pharmacy benefit management company that was much more reasonable and isn't sharing all these kickbacks amongst themselves, but giving them back to the employer. And that alone saves 10% easy. And also at the point of purchasing for pharmacy benefits or medications, the employees see a lot lower costs. So, and then direct primary care, and then some of those other elements.
Very good. What a great summation there. You know, it's also very interesting on this show to see how many doctors are helping lead the charge. So really, we always appreciate the doctors that are not just participants in medical care, but instead are actually trying to fix it. So that's great, and I appreciate being here today. I know Dr. Campbell wanted to kind of give you a little salutation as well.
Thank you.
Well, I know how easy it is to disappear into the fabric, go and do your job as a doctor and just get by to get by. And for guys like you who are willing to put your necks out, take a little heat, innovate, all because it's the right thing to do, hey, you get my kudos. So thanks for coming on the show, and thanks for doing more than just what everyone else seems to want to do. Thanks for being that 1%er.
Thank you very much. And thanks for having me, you guys. It's great. I look forward to digging in and looking at all your other guests.